I am Josh Sharfstein, the Vice Dean for Public Health Practice and Community Engagement and the Director of the Bloomberg American Health Initiative, and I'm very excited to be the host for a very interesting panel. So welcome to the people who are watching online. Thank you all for coming here. This is going to be a really interesting afternoon. I'm very excited about it. So let me explain what we have in store. We have 5 items on the agenda. 4 of them are easy to participate in if you are online. And one of them is the social hour, which is really just for people who are here. But we are now already in one, which is the welcome. So I'm giving you the welcome. After I finish, we are going to hear about this fascinating project, which I will tell you a little bit more about, and then you'll hear a lot more about from Dr. Weiner. So you will hear specific results from the project in 10-minute presentations. And then we have a fantastic panel, which I will introduce when we get there, who are going to be discussing the results, and then we're going to be opening up for conversation. So I think it will be very interesting as we look at a tremendous effort to bring data together and find interesting and worthwhile and actionable insights from that data for the opioid crisis that we're facing. Here are the goals. We are going to hear about the technical and strategic approach by this big data project. We're going to learn some of the insights that have been gathered from all these different important analyses. We're going to hear about practical suggestions and lessons for public health from this data, and we're going to talk about the implications of the findings for policy, not just in Maryland, but beyond. And I was the health secretary in Maryland when we started to see the increase. I think when I was first started, we did a press release that was like overdose deaths at all-time low, something to that effect. I mean, we had a huge decline, particularly in Baltimore City, going to 2010, 2011. And then we started to see them inching up again, heroin particularly, but as well as prescription drug overdose in some of the more rural areas of the state. And at that time, we weren't sure what was going on. And we were watching. We started things like overdose case fatality review in Maryland. We're the first state to do that, where people were looking individually, one death at a time. And as we're doing that, I think that has some value. It certainly crossed our minds that it would be great to do things not just one death at a time, but to really be able to spot patterns among all the different deaths, all the different tools that the state has to really understand what can be done to make a difference. And I think I had one meeting with this team, if I recall. I could be, I'll look for Jonathan to see if he remembers this to be the case. I think I had one meeting where the team came and said, we think we can help pull the data in before I left office. And then since that time, there's been this tremendous effort to be able to pull data in and answer questions that you just can't get from even looking at many deaths one at a time. This is why this topic matters. There are many reasons why this topic matters. This is just the fatality reasons of why this topic matters. Opioid-related deaths have really gone up tremendously in the state. At the time that I left, people were calling it a crisis, including myself, and then things doubled and went up from there. So it was just an incredible increase beyond what the state has ever seen before. The region that we're in Baltimore, including Baltimore County, which just released what I think is a very strong opioid response plan, has also been hit very hard. Anne Arundel County has been hit very hard. It's really the entire area here in central Maryland. It is, I think that we focus a lot on deaths, but I think it's very important to realize that Many lives are disrupted, first of all, for each death, tremendous circles of consequences for families and employers and communities. And then beyond deaths, all the people who are impaired by addiction, have non-fatal overdoses, or just can't do the things that they really do want to do in their lives, but they have really lost their ability to be effective because of addiction. It's just a tremendously challenging condition for the state, reflected in part in deaths and in part on all the other consequences. So today we're going to start to understand more about this challenge with a view towards the kinds of things that could really make a big difference here. And so with that, I am very pleased to introduce Dr. Weiner, who's going to be giving an overview of what exactly this project is all about. Thank you. I'll see you soon.
Thank you, Josh. And thanks all of you for coming, those of you here in the auditorium, as well as the 50 or 60 people that are online. This is a somewhat unusual event. We called it a mini symposium because the intent really is to have interaction. We think that we have something important to add to the discussion, but we are not the most important people in discussion. It's all of you. And it's a diverse group, the academics that you'll find around Hopkins, many from the public health community locally and nationally. That's one of the reasons that we've done that. We also are going to hear from a wonderful reactor panel to put this in the right context. In addition to the typical Hopkins type of presentation where we add new evidence, new insight, and I'm very excited that we'll have something like 12 peer-reviewed articles in very top journals, but that's not going to be the main focus today. The main focus today will be to take stock of some of our findings, but also our methods and our tools, and together to discuss this isn't so much an academic project, although it is an academic project. It's why most of us got into public health, to make a difference, to help our fellow community members. So I'm going to be giving a brief overview of the project, but also I have started with colleagues about 5-6 years ago, something we called the Center for Population Health IT, CPHIT, or CFIT. And what that's about is, all of you know, and it's been in the news lately, data everywhere, mainly to sell us junk. And, I shouldn't be quite so cynical. It does some good things too. But one area where informatics, big data, artificial intelligence, HIT, however you want to label it, really hasn't had the impact that it must have, is in public health. And so, for example, the project that we did, thanks to a very unique collaboration between the state of Maryland and not just the Department of Health, which was the anchor agency, but other collaborators who shared data that previously was used to run each individual program. We're among the first in the country. There are 2 or 3 others. One is Massachusetts. That's one reason we have a colleague from Massachusetts. But in general, the data are all in their silos and are not pulled together. And that is one of the unique aspects of this project that we're going to report here. So the first hour, now 55 minutes or so, will be myself talking about how the project came about, and to give a flavor of the big data representing our CFIT Center, but also not just for the opioid epidemic, but also many other applications within public health and population health. Then we'll hear from Lindsay Ferris. CRISP, Lindsay, we have 2 former doctoral students, now people with doctorates who were part of the team. That's always very exciting. Lindsay is a senior member of CRISP. Some of you might know we're blessed in Maryland to have one of the 2 or 3 best health information exchanges, HIEs, in the country. And they did something that couldn't have happened otherwise. They linked all the data in a confidential, secure way. So the researchers at Hopkins, for example, although dealing with the most sensitive data and handled in a secure way as if it were live medical records, we never knew who the individuals were. CRISP was the middle agent. Matt Eisenberg, assistant professor in health policy management, will talk to us about HSCRC data. Oh, I left out Lindsay, also from CRISP. The anchor database we used was the PDMP, the Prescription Program Drug Monitoring for Controlled Substance. You know that Maryland has a very high functioning PDMP. Many states do. And in fact, we were, to their credit, funded by the US Department of Justice. The US Department of Justice started, many of you know more than I about the PDMPs, for other reasons, but they recognize the public health applications. Noah Krasik, who also was a doctoral student and is now an assistant professor at NYU, and she will, hopefully we'll have enough time because there's so much to present. We'll talk about the linkage of corrections data. Again, the first time in my career that we have moved outside of the health and public health to linking all of the data from corrections. As you know, there's plenty of tie-ins there. And also, she'll talk a little bit about the opioid antagonist treatment, the methadone, et cetera, and others. And then Brendan Salinger, the co-PI with me, will bat cleanup and talk about the policy implications. So a lot to discuss. Again, acknowledging the Department of Justice, and also very importantly, this is an open academic presentation. We're not going to pull any punches. The opinions are just our own. They're not of the agencies that provided the data. They're not of the Department of Health, and they're certainly not of the Department of Justice. So but it will be an open academic discussion, pursuant to knowledge and trying to have an impact in ameliorating or at least addressing the problems the best we can. But that's a really important disclaimer. Okay, just real quickly, as I've alluded, big data is everywhere, not so much in public health. And these tools are absolutely essential to the future of public health. And guess what? In my opinion, the hard part has been done. Computerized data are everywhere. As you'll see, an amazing amount of data that's never really been pulled together in most places that can have many positive impacts. And if we were Google or Facebook or you name it, and all of those organizations, Microsoft, Apple, we'd figure out a way to monetize it. That wasn't our goal. We're figuring out a way to help people. So it's essential that we in public health and in healthcare play that game as well. Some of the positive, I don't need to tell you, data is everywhere. At this relatively late stage in my career, I've never had more data available for research. It is amazing. And my goal is to get everyone in the room and everyone listening to look at what matters to you most and find out how you can use that data to help people. Yes, there are challenges. We'll talk about them in a moment. And yes, we have new tools, new technologies. AI, artificial intelligence, machine learning is about 1/100th of what we need. The issues that we'll talk about today is the other 99/100th. And some of them are legal issues, human issues, political issues, and obviously clinical issues. But still, so many tools. And we in Maryland, both because, as I mentioned, of CRISP, also because of a lot of good work done by others, and the all-payer program that we have where the hospitals have to participate, and because of forward-thinking health department, we are really in a very positive position. This could not have happened without the Maryland Department of Health, without CRISP, and all of the sister agencies that provided data. It's not all rosy. I don't need to tell you. You don't just walk in and use the data. There are all kinds of legal issues. We had 2 or 3 lawyers on the team, and I can't thank them enough. The project would not have happened without public health lawyers. It goes without saying the data have to be handled confidentially. And if we have time, in fact, we have several papers. One of the paper talks about the way that we handle that. We're not in the National Health Service of the UK. We're not in Scandinavia. We all don't have an ID number. You just don't walk into 7 different databases across 5 years and say, let's pull all the data for Jonathan Weiner or Jane Doe together. Doesn't exist. So that was one of the challenges that we had to face. It isn't all clean. It's not standardized. It's not messy. And as I already mentioned, artificial intelligence, computers are great. Humans are better. We need a team of both. So also the Center for Population Health IT, CFIT, the organization that we have formed here at the Bloomberg School, our goal is to do just like we did for this project, to take the data and try to see how we can focus not on the single patient, on the single consumer, but on the community and on the population. And I encourage, happy to have a dialogue later. Again, moving very quickly, I think I've already presented all this, funded by the Department of Justice. The main goal, since the Department of Justice funds the PDMP, is to take the PDMP, controlled substance data, and use it to try to help patients potentially in trouble by predicting who is at risk. There are many ways that that's being done, usually on a very small scale. We at the Center for Population Health IT, CFIT, are leaders in the medical side. We've developed tools, something called Johns Hopkins ACGs, in use in 30 countries and, I don't know, 250 million patients. And it has a little bit of substance abuse and substances in the prediction, but it does not focus on it. So one of our goals is to take the technology that is widely used. Yes, there's some sensitive issues, both technical and confidential, but can we predict, based on the current situation, who needs some sort of intervention, clinical intervention or public health intervention? That was one of the main goals, if not the main goal of the project, the predictive risk model. And in fact, we had a working label of the project. Some of you heard about it, PRECOG. We don't use it much anymore. Precog was because it was predictive risk model. So that's what the focus was. Because the PDMP was the anchor agency at the Maryland Department of Health, but then because we brought in, and I'll show you in a moment, I think 5 other databases, the goal was if the state of Maryland collaborated, similar to 1 or 2 other states in the country, but I think we've even gone beyond that a bit, is there value not only for predicting people who could benefit from social and public health and medical intervention, but also learning. So the typical public health CDC buckets they sometimes talk about, individual patient, community, policy system, we definitely had all 3 goals, but because the PDMP's focus is mainly practicing doctors, our key focus, at least for the first phase of the project, was helping the clinician group identify people who could benefit from intervention. So as I've already mentioned, we had a unique collaborative, it couldn't have been done with any one of the organization. Our record linkage uses state-of-the-art, as CRISP, the Health Information Exchange, does for other purposes. Lindsay Ferris, I'm not sure you'll talk so much about it in your presentation here, but you have a whole paper on that. By the way, my goal is to have everyone in the room find something that interests them and wanting to learn more, either about the opioid issue or potentially other issues, because the techniques and approaches that we used, this interdisciplinary team, can be used for other activities. The linkage is one of them. We definitely were very cautious, and in fact even had a colleague from the Johns Hopkins Security Institute, as well as approval by our HIPAA czar and many legal colleagues at the same level of security and confidentiality as your and my medical record. So that's how careful we were, even though we had no names, addresses, or typical identifiers. CRISP had that information. We did not have that information, but that was key. And very advanced predictive analytics, advanced, typical in sophisticated econometric or epidemiologic studies. We have done many artificial intelligence study and machine learning. It usually doesn't add that much. That's a topic for another discussion for my informatics and computer science colleagues in the room, but we did apply those. So, in finishing up, the various databases we used, the anchor was the Prescription Drug Monitoring Program, PDMP data. We also used the HSCRC all-payer, all of the inpatient emergency room data. We did not use outpatient department data, which is in the possession of the HSCRC, in part because that would not include all the ambulatory data in doctors' offices not affiliated with hospitals. So basically, we had all of the hospital inpatient and all of the emergency department ED data in the state. All the Beacon specialty mental health programs, I'll let Brendan and Noah talk a little bit more about inclusions and exclusion. That is the special substance abuse treatment programs. Criminal records for drug and property offenses that in the possession of the Department of Corrections of the state. And using as one of our main outcomes and results, data from the Coroner's Office of the Chief Medical Examiner, OCME. And I can't thank enough the collaboration from all of these organizations. We also collaborated with the Department of Juvenile Services and did some separate papers. Thankfully, because there wasn't so much linkage with juvenile services data in some of this, we kept that separate. This project could not have happened without the collaboration of these organizations. And again, that is key, and it would be key for any projects you do. This talks a little bit about the linkage I've already described, where the agencies had the identifiers, the names, the addresses, et cetera, dates of birth. We never had that information. They provided that and their own unique identifier to CRISP, or the other way around. CRISP then took John Weiner, Jonathan Weiner, 1123, 1134, my address, a little bit wrong, but they decided that was me, and they assigned the same ID number to all of my records across all of the different agencies. This is state-of-the-art done for all of, when they try to sell us something and send you something that involves linkage from your web viewing or your bank account. This is the standard of industry. So again, our goal was to take these standard approaches and apply it to public health. So this is a very important point, because on day one, this was one of the biggest concerns. We never had the identifiers. CRISP never had the identifiers. They had the identifiers, but they didn't have the data. And we had the data without the identifiers. And so we spent a lot of time on this issue, and glad to talk more about it. But the end result is we had all of the data matched at probably 98, 99% accuracy across all of these databases, and we'll show you in a moment what we did with those data. Again, you're going to hear from 4 or 5 people today. It was a huge team. I won't read all the names, but we're so grateful. Some of you online, some of you here in person, but it was a collaborative, and there's some even not listed, I apologize that, as well as steering committees and others, some in the room from other organizations. So I think we are ready to turn to Lindsay, and I'm on time, more or less. So again, hold on to your hats. It's going to be very quick, sort of TED-like talks. Each person has 10 minutes. We're going to give each presenter a warning. They'll be over, but then we'll take questions and answers at the end after the panel. So thank you so much, and Lindsay, over to you.
Thank you, Jonathan. So I'm going to be talking about using prescription drug monitoring program data to identify individuals at risk. And the objective of this was to use the PDMP data for the variables and create a predictive risk model that would identify individuals at risk for any opioid-related overdose or illicit opioid overdose death. So the 2 data sets that we used for this study were the prescription drug monitoring program data. And as a quick background, the Maryland PDMP collects all Schedule 2 through 5 controlled substances that are dispensed within Maryland or into Maryland, if you're a mail order pharmacy, for example. There are several exemptions, so not all controlled substances are in the PDMP, and that includes any opioid treatment program, and that's covered by a federal rule that doesn't allow that to occur. Any substances that are administered by a health professional, so in an inpatient setting, for example, or skilled nursing facility. But anything that's kind of a prescription being dispensed to a patient that's going home is generally within the PDMP. The Office of Chief Medical Examiner death data, Jonathan mentioned, it's all investigated deaths within the state of Maryland and includes all intentionality. So we took these data sets and we linked them together, as Jonathan had mentioned, using the CRISP, what we call the Master Patient Index. It's a probabilistic algorithm. It looks at all the patient demographic information, like my first name, last name, date of birth, address, social security number, phone number, anything we can get our hands on. And it compares that information across the different clinical data sets. And we add up all the scores, and if it meets a certain threshold, we say that's the same person. And if it doesn't, we keep those as 2 separate identities. So that's how we've applied that to this effort, as well as to all the other data sets. And we created a person-level data set that included all prescription drug monitoring program-based variables. Some of them are simple, like the number of unique prescribers and dispensers, or certain drug types that we want to identify and look at as predictors. We also had slightly more complex variables, such as high opioid day supply, overlapping opioid and benzodiazepines, which are known to be cause people to be at higher risk for overdose, and high morphine milligram equivalent daily dose. And we looked at 2 outcomes of interest: any opioid-related death, both illicit and non-illicit, and that includes if there's any other kind of cause of death that were indicated in the OCME data, and anything that's an illicit opioid death that is mainly heroin and fentanyl, and no prescription drug also indicated as cause of death. So we did a retrospective analysis looking at Maryland residents age 18 to 80, and any individual that had an opioid prescription that was dispensed within a 6-month period in 2016 were included. And then we developed and validated our risk models predicting death in 2016. It was a logistic regression model. We used randomized split half validation. And then the model performance that we looked at was area under the curve. The area under curve indicates the ability for the model to discriminate between those that are truly at risk from those that are not at risk. And if you look at the literature, most of the models that are kind of considered to have an operational viability fall generally between 0.7 and 0.9. Those are kind of the most common range that you see that would have some sort of operational ability or application. So some quick results. I just wanted to show a few descriptive statistics for some of the variables that we had included in the model. We had about 282,000 individuals that were part of the retrospective analysis, and we had about 515 any opioid-related deaths, 315 illicit opioid-related deaths. The majority of the population were female, and the average age was 50. And then I want to show you the multivariate models. I'm only showing the variables that were found to be statistically significant predictors of the outcomes we're looking at, and just for brevity. And any opioid-related fatal overdose model is in the middle there. And the illicit opioid fatal overdose model is on the far right. You can see that there's not all of the variables that were found to be statistically significant in the any opioid model. Some of them were not found to be statistically significant for the illicit opioid fatal overdose model. But there's some protective factors such as older age on the 65 to 80 range. One of the highest predictors of the fatal opioid overdose for both of them were the opioid use disorder fills, which is really just a buprenorphine prescription, which is one of the treatment prescriptions that you can take home with you, and that's why it's being dispensed from a pharmacy and included in the prescription drug monitoring program. And so while while it's showing that it's high risk, it's really probably indicative of the underlying issues that the patient may have, such as having an opioid use disorder, because we do find that people who are enrolled in treatment, it's a protective factor. And if you look at the area under the curve performance of the models, they're both pretty comparable. They're 0.7 for 0.79 for any opioid and 0.78 for illicit opioid fatal overdose. And it's falling within that range that we commonly see in the literature that would have a practical application. So some implications. We found that we're able to use PDMP data to predict fatal opioid overdose. And we're also found it really interesting that we could use that it's comparable between any opioid deaths and illicit opioid deaths. So we actually can use prescription history information to predict if somebody could potentially have an illicit drug overdose. And as we mentioned at the very start of this, the illicit drug overdoses that are occurring in the state are on the rise, more so than the prescription drug at this point. And then also with the model performance and looking at kind of the details of the model, we did have a rare outcome which caused a low positive predictive value, which is the probability that the model is appropriately identifying those individuals that are truly at risk. And so we felt that the model may be best served as a broad public health tool to stratify risk and then perform additional screening on those that were found to be high risk. But we think that there's practical applications to applying a risk score universally to the whole PDMP population that could have impacts on program design and interventions and improving quality of care ultimately. And we do feel that the further research needs to be performed on the most effective approach to deploy the population level risk tools using the PDMP data. So that kind of practical application of it. And that's it. Thank you very much. Oh. Next up is Matt.
Thanks, Lindsay. Hi, everybody. My name is Matthew Eisenberg, and I'll be talking about using hospital data to identify fatal overdose risk. So we know from a lot of previous research before this project that rates of hospitalization have been shown to be higher immediately prior to overdose. And when we look at individuals who have had some type of substance use disorder or opiate use disorder hospitalization, they have a much higher fatal overdose risk. So if you look on the right-hand side of this slide, I've pulled some data from an article this team wrote that looked at over a 2-year period, calculated the fatal overdose rate among different groups. So over a 2-year period, 15 to 16, we see that the Maryland average overdose rate was just above 50 people per 100,000. But if we instead looked at the people who had had an emergency department visit during that period, their fatal overdose rate is almost 100. So it moves from just over 50 for the Maryland average to just under 100 for those who've had an ED visit. If we look at people who've had an inpatient hospital visit, the overdose death rate is now just above 100. And if we look at the denominator of individuals who had, over this 2-year period, an inpatient visit and an emergency department visit, you see the overdose death rate is almost 200 per 100,000, which is much higher than the just above 50 for the Maryland average. And just to clarify, these are inpatient visits and ED visits for anything. This is just showing up in these service areas. So this gave us a lot more evidence and interest in digging in more into the hospital data and understanding more about how hospital utilization could influence fatal overdose risk. So the goal of this study was we understand, based on Lindsay's wonderful presentation, that PDMP data can be used to predict fatal overdose risk and has some real operational viability in doing so. And there are a variety of states that have begun to do this. So this study said, let's try to expand on that by deriving and validating a predictive risk model that uses that PDMP model as a base and adds in the hospital predictors. So we're going to similarly focus on a group of individuals who had at least one prescribed opioid during a 12-month period. And then we're going to say, we're going to answer 2 questions. One is how are various PDMP factors associated with fatal overdose? And second, how are various hospital-derived factors associated with fatal overdose? And then how does the model validation and the model fit statistics change once we add in these hospital predictors? Does adding in the hospital predictors give us a lot more predictive viability? So the data sets we used, this is again for the state of Maryland from 2015 to 16, and we're going to be using 3 main data sets. We're going to be using the PDMP data, which is all controlled Schedule 2 to Schedule 4 controlled substance prescription records. We're going to be using the hospital discharge records, and as Jonathan mentioned earlier, this is all of the inpatient and emergency department records. There's no outpatient records in this analysis. And these hospital records contain information on what the patient was diagnosed with when they were at the hospital, as well as what procedures they received when they were there. And then our outcome measures are going to be derived from the Office of the Chief Medical Examiner data, which is going to be all investigated opioid overdose deaths. Our sample here is going to be Maryland residents aged 18 to 80, and as I mentioned earlier, who were prescribed at least one opioid during 2015. We're going to split our data in half so we can train the model on one set of data and derive the model on one set of data and then say, all right, now let's take it to a totally different set of data, and that's how we're going to assess model fit. So we're randomly going to split things into a model development sample and a model validation sample. And you'll see just some descriptive statistics on the right here. It's thankfully a rare outcome in this sample. Opioid, any overdose death is just 0.1% of the sample. About 2/3 receive their opioid prescriptions from one prescriber, with 1/3 receiving their opioid prescription from 2 or more prescribers. About 1.3% of this sample had some hospitalization with a diagnosis code for opiate use disorder, and only about 1.1% of the sample had some non-fatal heroin overdose in the hospital. We're unable to see non-fatal overdoses that occur that don't result in some type of hospital interaction. I'm not going to go through all of these variables on the right-hand side, but basically what we did is we estimated a series of multivariate regressions with 2015 data predicting death across 2015 and 16. And we're going to test models, as I said, with different sets of predictors. We're going to start with just the PDMP predictors and then add on the hospital predictors to see how the predictive power of the model changes. We have very similar PDMP predictors as Lindsay just presented, so I won't go over those again. Our hospital-derived predictors are things that we know from the literature are associated with fatal overdose risk. So we have in there flags if you had some type of non-fatal overdose hospitalization, what type, how many, and we have flags for an opiate use disorder or non-opiate use disorder, substance use disorder, hospitalization, as well as flags for commonly co-occurring conditions like chronic pain or some type of skin abscess. And then we've got some covariate sex, age, modal method of payment. These results, and similarly, I'm going to focus on the largest coefficients and the most significant ones just for brevity, but these are the PDMP predictors, and in bold are the ones that are statistically different from 0. And what I want you to take away from this slide is the odds ratios on these PDMP predictors are mostly between 1 and 2, with the exception of those who had a large number of benzodiazepine fills have an odds ratio of about 3. But mostly between 1 and 2 when we look at these PDMP predictors. When we add in the hospital predictors, we see odds ratios that are much, much higher. So if we look at this, we see for individuals who had a non-fatal heroin overdose, there's an odds ratio of over 5. We see if you had an opiate use disorder hospitalization, an odds ratio of almost 7. So these hospital-derived predictors really are associated with a high amount of risk. We then wanted to ask ourselves, well, one, how is this model doing? Let's calculate those area under the curve statistics so we can understand how effective the model is at prediction. But then we also want to say, what are different possible use cases for this model? On one hand, it's feasible to think that a hospital system might have PDMP data and develop some PDMP risk score, but it might be harder for behind the scenes in an EHR data to link together and estimate a model with PDMP and hospital data. So can we get some additional predictive power by using our PDMP model and just adding some simple flags like showed up in the ED or had an opiate use disorder hospitalization? And what we see on the left-hand side, you have our model fit statistics for any opioid death. And on the right-hand side, we have our model fit statistics for an illicit opioid death. I'm going to focus on the illicit because they're the most striking. We see that just using the PDMP and demographic variables, we have a fit statistic of about 0.84. If we add in the full host of hospital predictors, we get a significant jump in fit from 0.84 to 0.88. However, if instead of using the full slate of hospital predictors, if we just include hospital predictors for showed up to the inpatient for anything, or showed up for the ED for anything, you get about half the way there with a fit statistic of 0.86. So the full slate of hospital predictors, you go from 0.84 to 0.88. If you include just simple flags, you get about half the way there. So to wrap up, We found that adding predictors from hospital data can improve the utility of a predictive risk model. And in thinking about different use cases here, as I said, clinicians can see PDMP data in the EHR. They have access to that in the state of Maryland. Hospitals have access to their own EHR data. Perhaps, though it might be difficult to combine all of this information into a risk score that was running behind the scenes, if people were aware of these results, they might be able to say, all right, I see the PDMP data. Let me look in the EHR to see if one or two of these flags show up in the EHR. So thank you so much. Next up, we have Noah.
Hi, everyone. I'm Noah Kravchik. I'm now an assistant professor at NYU, but I had the pleasure of being part of this team while I was doing my PhD here, and this project really was the basis for my thesis that I'll be talking about these pieces today. So just to give some very quick overview about why we're interested in looking at corrections risks for opioid overdose, we know that people who are involved in the criminal justice system have very high rates of opioid use disorder. We also know that people in the criminal justice system have very high risk of overdose, in particular during the time of release from detention. So compared to the general population, we know that in the first 2 weeks from release from incarceration, people have over 100 times greater risk of overdose death. What we also know is that even though a lot of people in the criminal justice system are receiving some kind of treatment for their opioid use and other substance use disorders, we know that few have access to the best type of, or the most effective type of treatment that we have with opioid agonists, which I will refer to as OAT throughout this presentation, which refers to methadone and buprenorphine. So as I mentioned, we know that people that are justice involved have high risk of overdose upon release from incarceration. What we don't really know is what specific demographic information, what criminal justice characteristics, as well as what health characteristics are really related to this risk. And so what we wanted to look at using the data in this project is how we could link corrections data with data from hospitals as well as mortality data to really try and identify which characteristics are most associated with overdose risk among this high-risk population. And so for the years 2013 to 2016, we linked data from corrections in Maryland. So this included arrests, incarcerations, and parole and probation cases for specifically drug and property crimes during these years. We linked this to hospital data, so as Matt mentioned, emergency department and inpatient hospitalization data, and finally to mortality data from the Office of the Chief Medical Examiner. And we linked this all at the person level. And what we did is we did a risk factor analysis to really try and understand which sociodemographic, criminal justice, and hospital use factors were associated with greatest risk of overdose. And we found that almost 90,000 people had some kind of corrections record during this time. As you see, a lot of people had overlapping records for incarcerations, arrests, and parole and probation. And the majority of this population was between the ages of 18 and 35. The majority was male and Black. And we found that, interestingly, over 50% of people that were involved in the criminal justice system also had some kind of hospitalization record during this time, often due to substance use and mental health related issues. And of the people in our criminal justice database, we found that 519 died of overdose during these years. And kind of following greater trends in Maryland, we saw that during later years, this was largely due to fentanyl, even though in earlier years, this was driven by heroin and prescription opioids. And here, this figure here shows different risk factors for overdose death. In red, you'll see these are factors that increased risk for overdose, and in blue, factors that reduced risk of overdose. And I'll just point you to one interesting finding, which was that people with criminal justice involvement, if they had any type of hospitalization for any condition, they were at much, much greater risk of overdose death than anybody else. And when we looked at this through a predictive risk model, we really found that if we only included information just about basic sociodemographics, what type of criminal justice involvement a person had, and just a flag for having any hospital encounter, similar to what Matt described, we really had very good model discrimination to understand who was at greatest risk for overdose death. So moving on to a second study that we looked at using this data is, as I mentioned at the beginning, we know that justice-involved people often seek treatment, and yet they have low access to methadone and buprenorphine or opioid agonist treatments, OAT. But what we don't really know is what factors specifically about people who are in criminal justice are related to whether somebody receives treatment with these agonists or other types of treatment that don't involve medications, and also how access to these medications actually directly influences overdose risk among this population, which you just saw has very high rates of overdose. And so this time we linked the corrections data to substance use treatment data as well as mortality data to understand the characteristics that are most associated, first with whether somebody receives opioid agonist treatment at all, and second, whether somebody is at greater risk for overdose. And so this time we used data just from 2015 and 2016 because this is the time period for which we had treatment data. Again, we used the same corrections database, but this time we linked it to outpatient treatment episodes, specifically for opioid use disorder that took place in the state of Maryland, and linked this to medical examiner records to look at risk of overdose death. And we used multivariate logistic regression to look first, as I mentioned, at correlates of opioid agonist treatment, and second, to look at factors that were associated with higher overdose death risk. And so we had a little over 40,000 people that had criminal justice records just during this time period. And interestingly, we found that there was a pretty large presence of people who are also accessing opioid use disorder treatment during this time. So almost 20% of people in this entire criminal justice database for drug and property crimes also had sought some type of treatment for opioid use disorder. Just interestingly, to point out some differences that we found between people who had opioid use disorder treatment records during this time and other justice-involved folks that didn't, we found that those with treatment records were more likely to be female than those that weren't seeking treatment for opioid use disorder, were a little bit older, were more likely to be white, were more likely to have a drug charge as compared to people who only had a property charge, and were more likely to have a misdemeanor only, meaning they didn't have a felony at all during this time period that we looked at. And this is similar. Here's a display of also the risk factors, this time looking at access to opioid agonist treatment. So the red indicate factors that were associated with reduced access to opioid agonist treatment. And in the blue, we look at factors that are associated with higher access to opioid agonist treatment. And I don't think this is on the slide, but a little bit over 50% of people who were receiving opioid use disorder treatment had any type of opioid agonists involved in their treatment. And interestingly also, being male or being Black, having some kind of other substance use problem in addition to opioids, as well as specifically being referred to treatment by the criminal justice system, all reduced likeliness of being treated with opioid agonists. And this meant that so everybody in this database had some kind of criminal justice involvement, but specifically those that were referred by the criminal justice system had lower odds of receiving this treatment. And then, as I mentioned, we also wanted to know how receiving opioid agonist treatment how that impacts overdose death. And we found that of all the different types of treatments for opioid use disorder that people were receiving, only opioid agonist treatment significantly reduced risk of overdose death. So just some overall lessons from these studies. We did find that justice-involved persons have high risk of overdose death, and yet they're less likely to receive opioid agonist treatments. So this really implies that our health and criminal justice policies really have to improve opportunities for linkage into our most effective known types of care. In terms of the implications for this type of data linkage, is we saw that by linking data across these systems, we are really able to identify persons that were at highest risk. So really, if we more often were able to link electronic data together, we would be able to really possibly target interventions specifically at people that we know are at highest risk. And now I'm going to switch gears a little bit to another study that wasn't looking specifically at corrections populations, but really looking at people in Maryland in general. And here we were really interested in looking again at this issue of opioid agonist treatment receipt. And as you saw, as I just spoke about, many people in the criminal justice system don't necessarily receive opioid agonist treatments, despite our high understanding that they're very effective. And even though and this is also similar in many other populations that are seeking treatment where opiate agonist treatment is not always part of care. What we don't really know is how this impacts risk of overdose death across the population. So I will discuss this last study where we really linked treatment data for the whole state of Maryland to mortality data to understand the difference in risk among people who are receiving opioid agonist treatment compared to people who are receiving treatment for opioid use disorder, but only with behavioral therapy. So I call this non-OAT because it doesn't involve medication. And specifically, we're interested in how this risk compares while people are in treatment, but also given there's a lot of turnover with treatment, we also wanted to know how this risk compares when people leave treatment, so after treatment discharge. And this time, we linked also data for the same years, but specifically we looked at treatment data for any opioid use disorder specialty treatment episode, and we linked this to mortality records. And we used survival analysis to look at the differences in risk both during treatment as well as after discharge. And what we found is almost 50,000 people had received opioid use disorder treatment during this time, and about 371 people died of overdose from this population. And this chart looks at the distribution of the time that people spent across the entire population throughout these 4 categories of risk. So during non-opiate agonist treatment, during opiate agonist treatment, and then after opiate agonist treatment, so once they had left that kind of treatment, and after non-opiate agonist treatment. And what we found is that compared to periods of time in treatment without medications, treatment with opiate agonist treatment reduced overdose risk by over 80%. However, when people left treatment, whether they had left opiate agonist or non-opiate agonist treatment, they had equally high risk of overdose compared to the time that they were in treatment. So just another way to look at this is through these survival curves. On the left looks at overdose death during treatment. So as you can see, folks in the blue line that are receiving non-opiate agonist treatment are dying much quicker than people that are in opiate agonist treatment. And the graph on the right shows what happens when people leave treatment, and you see that whether they had been receiving opiate agonists or non-opiate agonist treatment, people are at equally similar rates of death. And so just generally, we found that opiate agonist treatment reduces overdose risk compared to non-medication treatments, but that this is no longer effective once treatment is no longer ongoing. And so we really want to emphasize that health policies have to promote use of not only entry into medication treatments, but also retention and continuation in care. And lastly, we saw that linking treatment and mortality data allowed us to really understand the impact of treatment on the population at the population level. And so we can really look at long-term outcomes using these strategies more so than we could with short-term data. So yeah, thank you very much, and hand it over to Brendan.
Now we'll pass out the quiz. So it falls to me to just offer a few summary thoughts on this project, and then really looking forward to the comments from our discussant panel. So I'm just going to quickly sum up what I think are 6 major really important findings and offer some recommendations related to policy and practice that I think flow from those findings from this study. The first finding, which perhaps is not surprising to those of us in the field, is that fatal overdose is a highly concentrated phenomenon. So we looked at this sample of 3 million Marylanders, and basically what it boils down to is that you can really see several risk factors standing out as making people incredibly at risk of overdose, including, and this is perhaps not surprising, a history of non-fatal overdose. And this says that we really need to be aggressive in this state about scaling up programs that try to do more intensive case management and outreach to overdose survivors. And that includes the Overdose Survivor and Outreach Program. And it's also really important to track this population. We don't have good data systems currently in place that allow us to track these populations on an ongoing basis. We need to understand whether we're making progress in helping overdose survivors. The second finding, going back to Lindsay Ferris's presentation, Overdose risk can be accurately identified within populations tracked by a prescription drug monitoring program. We saw from Lindsay's presentation this was possible using only 6 months of data. When we allow ourselves to view a full year of records, we get an even higher fit statistic to our models. So this speaks directly to actions that the prescription drug monitoring program could take here in Maryland. We believe that our model provides a proof of concept for how a risk score could be developed as a decision support tool in the prescription drug monitoring program. Essentially, what we'd like to see is that the prescription drug monitoring program will be able to distill for people who are using the prescription drug monitoring program information about the risk of overdose for particular patients. Now, it's important not only that risk information is there, but that clinicians who access the prescription drug monitoring program know how to interpret that risk data. And equally important, that they have access to resources that allow them to help their patients once they find out that those patients are at risk of overdose. The last thing that we want is risk information to be used as a tactic to cut patients off from care. We think that the key strategy here is identify patients that are at risk, but couple that with strategies to provide them with access to treatment and harm reduction. Third finding, from Matt Eisenberg's presentation, hospital records are a very useful tool for capturing a range of risk factors spanning diverse populations, so people who may only have moderate indicators of risk and an incredibly concentrated population of high risk, numerically small group, but very high risk, for example, overdose survivors. Hospital data should absolutely be prioritized for future efforts here in Maryland, focused on surveillance. This is a real trove of information that could help state policymakers understand how risk is evolving within the state. And the quality of data here in Maryland is very good. The reach of the data is very extensive. It's a great window into risk. Hospitals are also, it should be noted, a critical site for interventions that can reduce risk. And in particular, hospitals are a great place to start patients on medication treatment, and we've been seeing progress in that area in Maryland in recent years. We could be doing a lot more to make sure that if a patient is seen in a hospital for overdose, that they're not simply sent on their way without any further resources. Rather, we'd like to see those patients started on treatment when they're in the hospital with a great discharge plan. The fourth finding, patients treated with opioid agonist medications have much, much lower overdose risk than those treated without medication. That was clear from what Noah was presenting in her final few slides. This is known to the field, frankly. We've known this for a long time, and yet we still see widespread opposition to providing greater access to opioid agonist medication. I think it's critically important for us to show in this study that the thing that had been known from clinical trials also really stands out in these population studies. We need to ensure that medications are available at all of the facilities that receive state grants. The state has the ability to influence how patients get access to these medications. Maryland is above the national average. We could be doing even better. And we also need to focus on reducing the stigma against medications that is still pervasive among medical providers. Let's call it out for what it is. Giving patients access to opioid agonist medications is not substituting one addiction for another. It's providing patients with a life-saving evidence-based treatment. Fifth, and this is again from Noah Krawczyk's findings, patients who have justice involvement, so a history in the criminal justice system, have much higher overdose risk, and yet those patients in particular are less likely to receive those medication treatments. I think critically here, this doesn't fall just on the criminal justice system, and this doesn't fall just on other systems. We need to find ways to improve partnership between health providers and jails. And we need to build on the recent legislation that has been enacted here in Maryland that encourages greater use of treatment when people are incarcerated. It's also important to note that we weren't looking just at people who are incarcerated. We also saw a population of people who may have come into contact with the justice system through an arrest. And so we also need to focus on what we would call the front end of the justice system. We need to work with police departments to make sure that when people are arrested, that they're promptly screened during that encounter and linked to treatment. I think law enforcement is a real untapped resource in the state in terms of finding more ways to give patients pathways into evidence-based care. And then finding number 6, it's a finding that really speaks to the value of data and data as being the platform for all that we do in public health. So through this unique interagency agreement with lots of lawyers, as Jonathan said, and an academic partnership, This project showed the potential of data-driven approaches to support overdose surveillance. We need to sustain this progress, and I'm happy to say that here in Maryland, legislation has been passed that will allow for ongoing data linkage, and we're very excited to hear from Michael Bayer, who has been shepherding these efforts through the Chapter 211 program. I think it's also important for us to think about, well, what are going to be the use cases? These different presentations, I think, in various ways drew your attention to ways in which these data could be used by practitioners, but I still think that there's an important level of thinking and planning that needs to go into, well, you know what the risk factors are, how are you going to use them, what are going to be the legal and data sharing frameworks that can guide our continued efforts in this, in the goal of overdose prevention. So overall, I think these data linkage projects represent scientifically a major step forward. And I would just emphasize that I think through this project, we were able to create knowledge that was not possible when we just looked at siloed data systems. So for example, we now know that people who have fentanyl-involved deaths also are very likely to have high rates of PDMP contact. That's something that I think has not been part of the narrative. We talk about the overdose crisis as if there's two very distinct populations, patients who use prescription drugs and patients who use illicit drugs. I think our data show that actually those populations are more overlapping than has been previously characterized. Future directions. I'd love to see more cross-state partnerships working with states like Massachusetts to share our knowledge and to see whether our findings are consistent or different in different places. And using linked data, I think, for real-time interventions. This was a look back at historical data. We want to be using linked data on an ongoing basis to make real-time decisions. So I'll conclude with just some thoughts about what we learned as researchers. This is a picture of me in 2015. I had about the same amount of hair then as I do now. So let me be a little immodest. I think we had an excellent team, great state partners, thoughtful lawyers, an engaged steering committee, and those things all worked in our favor. And yet we learned some really important lessons through this project. We need to think about how data are going to be used up front, be selective in data set creation. We were confronted with a massive trove of data. We couldn't use it all, so we had to be very thoughtful about how we were going to pare that down to just a few analytic data sets and a few variables that we focused on throughout this project. And also recognizing that this is a very dynamic issue. Academic research tends to be slow. You know, I'm aware that these are data that go back to 2016 that now seems like eons ago in our overdose crisis, so we need to be doing this work on a more real-time basis. And I think that the hard work is yet to come. So the science is there, but the science needs to be partnered with good strategies. And so I'm really excited to hear from our reactors about what some of those strategies might be. Thank you so much.
Great. I'm going to ask our panel to come up, and I'll introduce you all as you're coming up. We have Dr. Alex Wally, an associate professor at Boston University's School of Medicine, who has studied the opioid epidemic as well as taking care of many patients with opioid use disorder. David Horrocks, who is the CEO of the Maryland Health Information Exchange. Michael Bayer, who is the director of the Office of Opioid Response Coordination at the Department of Health here in Maryland, and Regina LaBelle, who is a distinguished scholar at the O'Neill Institute at Georgetown and former chief of staff to the Office of National Drug Control Policy. So welcome you all. We have a few questions, but I also want to give, because this is an academic forum, we had some great presentations. You all should feel free to ask questions along the way if there was something that wasn't clear, and I can invite people up to answer them. But maybe I will start with one question that I had just sitting there trying to understand, which had to do with the PDMP. You had the PDMP data for the state and all of the overdoses for the state. How many of the overdoses were in the PDMP data? Wasn't clear to me. Yeah, come on up. Just.
So I'm going to get the numbers approximately right. I'm looking at Matt, who knows the exact numbers, but I want to say it's in the ballpark of about 40%.
That sounds right to me.
Yeah. The data set that captured the most number of overdoses was the hospital data. So our kind of take-home message is if you only have one data set to use the hospital data, but the prescription drug monitoring program came in second.
I think one important thing to note.
Mm-hmm. Come on.
One other important thing to note with that is if we look at the universe of overdose deaths in 15-16, about, again, I'm going to get the exact number wrong, but about a third to 40% appeared in no data set before they showed up as an overdose death. So there's still a large chunk of individuals who go on to fatally overdose that do not interact with any of the data systems that we talked about.
Good. Well, I just wanted to kind of set the stage a little bit so that we can understand as we talk about the implications of this for policy. So I wanted to start with a question about, some of these things I would describe perhaps as confirmation of things that are generally pretty well known in the field, and other things might be a little different. So I wanted to turn to the panel and see if there was one particular thing in all the different presentations that was a surprise looking at this. David,
Yeah,
you
one
got
thing
one?
that surprised me, I'd expect age to be protective of an overdose. Middle age is not protective of a lot of health events, but I think it is of overdoses. But for people who have been involved with the justice system, it appears not to be. It appears to be the opposite. And I thought that was counterintuitive.
Okay. I'll ask one. I spotted in Lindsay Ferris's presentation that having a greater than 91-day supply of opioids had a dramatically reduced odds of overdose. Did that surprise you at all, Dr. Wally, or were you expecting something like
Sure. I mean, you can read that two ways.
Mm-hmm.
You could say that I would consider 91 days of opioid prescriptions to be chronic opioid therapy, so more than 3 months of a prescription, whereas less than that would be kind of acute treatment for a pain condition, presumably. Right. So it looked in that analysis like there was a higher death risk in the group that had the acute pain prescription rather than the chronic pain prescription. That's how I kind of interpreted that, and I was also surprised by that because we've read study after study about chronic opioid therapy and its association, especially at higher doses, but really it's not that effect we think of as thresholds because of the CDC guidelines, where there's a 90 morphine milliequivalent per daily dose threshold. We think of it as thresholds, but actually it's a continuum from low to high doses. And so that also surprised me.
Yeah. Any other findings on here that jumped out at anyone? Michael, Dave?
I'll just say nothing that was particularly surprising. I just want to second the finding around the protective nature of opioid day supply in the PDMP only model, and also coupled that with what looked like a pretty or a lower risk ratio for some indicator of chronic pain in the model that links in the hospitalization data as well. I think it does reinforce some of what we've been hearing for a long time from patients who have been receiving treatment with opioids for chronic pain, that in and of itself does not necessarily equate to higher overdose risk. I think it's something that's noteworthy.
Regina?
It was not necessarily surprising, but I think it may be a question for the researchers. We've seen in Massachusetts that one of the greatest at-risk groups are postpartum women, and I didn't see that in any of the research, and I was wondering if there was any other additional information on that. Okay. Okay.
So the point was answered, just for people watching, is that that was not assessed in the study. Okay. I'm going to ask the flip here. What didn't surprise you in the findings? What did you look at and say, that if you had asked me beforehand that they were looking at this, I would have guessed something like this?
The efficacy of opioid agonist therapy compared to other modalities for opioid use disorder, one thing.
And both in the overall model and in the model of people in criminal justice. Mm-hmm. Could anyone want to elaborate on that a little bit? Maybe Dr. Waller, you prescribe those
I
medicines?
This was very confirmatory, I think, of known risk factors and protective factors for what we know for overdose. And so the strength of the association with medication for opioid use disorder when people are on the treatment is not surprising, but it's confirming because we've seen it in lots of different studies and lots of different populations. So it's good. I think it says something that this data set can tell us sort of things that we already know in a different population, essentially, which is the people of Maryland.
It's also validating to the data set itself.
Exactly.
In a way.
Exactly. And that's true for, in the initial study, all of the risk factors found in the predictive model to predict overdose that are in the PDMP, those were all things that, except for I think this one we mentioned, were sort of confirming. And there weren't a lot of surprises there, I would say.
So I want to focus for a second on the fact that the hospitalization was so predictive, and they didn't even need to get to the detail of what people were hospitalized for. At least there's a big association of risk with people who are hospitalized, and I wonder what you made, how you think about that finding. Could it be that it's basically, part of that is that people were hospitalized for nearly dying for overdose, and that is putting them at great risk for dying from overdose. But more generally, how do you interpret that in this context? I don't think people have thought of hospitalizations per se as a risk factor, and what's the right way to start to think about that kind of finding?
It raised questions for me. I wondered whether there's is the risk greatest just after a hospitalization, or if there's been a hospitalization in a year ago, or is it just as predictive? And so it raised those questions. And then for people who've been in the justice system, it seemed like a hospitalization itself had a higher odds ratio than specifically a hospitalization for accidental poisoning or overdose, which, what's up with that? I'm not sure.
Alex? Sorry. Regina, were you going to say something?
Sorry. So it looked like from the, the hospitalization with the incarcerated population or people who were justice involved, that it might be indicative of other behavioral health issues and pre-existing substance use disorders. And again, which we've said for years, another opportunity to intervene in the hospital system. Because I think when we work in criminal justice systems, we think that's the only opportunity for intervention when there are many other opportunities as well.
It's an interesting point. Alex?
So I really was not surprised by that.
Yeah.
So I wrote, hospitalized patients are sick and risky. And if you've ever, I'd spent a lot of time, including in Johns Hopkins Hospital, taking care of patients. And if you've taken care of patients in hospitals, they're really sick. That's why they're in the hospital. And so this is a real issue of cohort and risk selection. So if you want to find really sick people, go to the inpatient hospital. So I don't think it's a surprise there. And then, it turns out if somebody's young and sick in the hospital, the chances that they have a drug problem and they're at risk for overdose, I think are going to be even higher because young people generally aren't hospitalized. But when they're hospitalized, it's due to things that overlap or are much more likely to be relative to substance use. So I think hospitalized patients, it's not just a risk factor. It's a really bad prognostic sign for your health if you get hospitalized. So not surprised at all by that. And it's a bigger health deal to get hospitalized than it is to get incarcerated. I mean, you're medically ill, whereas you're not necessarily if you go to jail.
Great. And then, of course, if both of them happen, then you get double it's an increase in the overall risk.
But the implications are great. These are both in incarceration, literally captured. Also in a hospitalized setting, these are people who are captured in a health setting. There's so much opportunity to not only identify people at risk, but as Brendan was mentioning, there's potential for us to figure out interventions and ways, things that we can do. It's one thing to think about that. It's another thing to actually to figure out what works. Brennan mentioned initiating medication in both venues, which I think is a logical place to go, but unfortunately isn't happening.
I want to turn to that in just one second, but I want to press one issue here, which is whether there could be some element of causality with overdose, with hospitalization or incarceration. Take incarceration first, that people may lose their tolerance and be at risk for overdosing when they leave. In a hospital, that similar thing could happen if people are not treated while they're there. So partly the incarceration, I'm testing this, you guys be a little provocative here, partly it could be just that it is a risk factor. Somebody is just sicker in their illness and they get hospitalized or perhaps incarcerated for that reason. Or is there a parallel explanation that actually these events themselves may increase the risk of overdose? What do you think of that idea? But either one or both could explain the findings here.
I mean, I think definitely in the incarceration example, I think there's been plenty of research over years showing that to be the case. The effect of incarceration as a sort of shock to tolerance for people who are regularly using opioids, and the drastically increased risk in the first few weeks after release. I mean, I think that is definitely the case there. I think that especially in the jail setting, where you have a lot of churn among a pretrial population, I think that's a place where you're going to find a lot of that.
So I'll just add to that. I mean, that's the elegance of the Binswanger study that was shown, and I think it was Noah that showed that study. It was that they integrated time into essentially the observational cohort study, and that is a place that we need to go with these data analyses, is really trying to get more fine-pointed views on timing of health events, trying to get down to the day level. So essentially the Binswanger study got to the week level, and I know in Massachusetts we have struggled with our data in trying to fine-tune around time. And so that's where a lot of, I think, the data science work needs to go to help us, because with time, it's not the same as a randomized controlled trial, but you get much closer to being able to establish causality if you can order events in time. So this gets at this point with the hospitalization. We don't actually know until we look at whether there are more events in the week after the discharge, or the 4th week or the 5th or the 6th week after discharge.
Yeah, in Maryland on the incarceration, the health department found that same time issue with the substantially increased risk of death in the first week, then declining after incarceration, both in jails and in prisons, if I recall correctly. So, which gets us to, I just want to explore whether there are any other major findings that you all want to put on the table before we switch a little bit to the policy discussion and then take questions.
Well, I know the title of this is to combat the opioid epidemic, but I think the polysubstance use can't be stressed enough, and that came through in a couple of the studies, and that was really important.
Great. Okay, well, why don't we start talking about what can be done? I think the fact that you have individuals who are at high risk, perhaps their risk is worsened when they're in incarceration and potentially under some circumstances when they're hospitalized. And yet, many people in those settings are not getting treatment, even now, even in 2019. And I'm not just talking about Maryland, I'm talking around the country. So how do you think about the A, the implications of the data, but B, the limits of the data to kind of change that policy? I know, Regina, you've been very involved, particularly nationally, in trying to change those kinds of policies. Where does this kind of analysis fit into that discussion?
Well, it can't be stressed enough, the risk factors, and that we can follow the Rhode Island model and reduce overdose deaths for the entirety of the state by addressing and getting help to people, opioid agonist treatment behind the walls while people are incarcerated. And that is an incredible opportunity for intervention. It will save lives and it will save money and improve the health outcomes for the entire state. So this type of work, it just has to be stressed again and again to get the message out. And while this was specific to Maryland, obviously we've seen it in a lot of other states. And so it's just important that we continue to amplify this type of work.
You know, question for David here. You have this issue of people in the hospital being at very high risk. And I know that CRISP, the Health Information Exchange here, has all kinds of tools for hospitals to take better care of patients. Did this kind of spur any ideas for things that could be done to help people who are at high risk in hospitals get the kind of treatment that they need?
You know, one of the things I thought about is the challenge of effective patient matching, and also the challenge of getting the important insight into the right hands. I think the health systems are replete with important insights that don't get to a primary care provider or to a treating clinician who can do something about it. And so if we have a great system for predicting risk, how do you get that insight to the right person at the right time? And I think it's tough.
Well, let me just pick up on that. The right person at the right time. And this is the question I want to ask. Is the right person, you know, someone right there with the patient who may get something saying there's a 6% chance of something happening, you know, something like that? Or is the right person the hospital administrator who may get something saying when people leave your hospital, they're at elevated risk of death for the first week and you're not providing treatment to people when they're there? So, you know, CRISP gives great reports to hospitals on their aggregate rates of readmission. So where is this data going to be most influential? Is it, and I appreciate the thought that maybe this would be really valuable at the patient level, although I have my doubts, versus the value at other levels where people who are in a policy position to change the policy of the hospital or the jail may be able to see their ongoing progress, to put it in a nice way. I don't know where you would fall. Where would this data really be helpful at the point of impact?
You also left off public health officers, like county health officers, who have certain interventions. Could they use the information? That's also where my head went. We are giving them overdose information today and trying to improve that.
Yeah, I recall a time when the state health officer announced that there would be a mandatory reporting of non-fatal overdoses so that there could be public health follow-up. That public health officer moved on to an academic position, and that did not actually go into effect. But nonetheless, Alex, Regina, would you want to comment on where you, or Michael, where you think this data could be most useful? Is it at the clinical level? Is it at the institutional level? Is it at the policy level? You know, don't say all of them. You can't say that. Which is the one that you would like to see and why?
I mean, at this point, I prioritize essentially at the institutional level. I just think given the profile of this issue, the level of conversations that are happening between different systems. I mean, in Maryland right now, we have legislation that's going to mandate our correctional facilities to implement health services with opioid agonist therapy and other medications for treatment in a phased approach. I think it's an incredible opportunity for health officials and correctional officials to, make decisions around how to do this while looking at data. That is the result of these types of projects. We're able to, characterize profiles of risk among different populations and subpopulations that both or all these different systems are serving. I think it's really critical that we do that right now. And, with this project, I know that the Hopkins team knows this. I mean, all along the way, I've always, had some level of concern about the viability of getting to that patient level. I mean, just the complexity involved, of the scoring itself, the interpretation of a score by different folks in the health or other systems, and the potential for unintended consequences there. So I think that we should always be talking about that and looking at it as a possibility, but while still recognizing that the risks are much greater at that level.
Alex?
So I'm just going to sort of say those things in a different way, what you said. So I feel like the provider-patient level is not the right place. What we already know about PDMPs is they will decrease opioid prescribing. That's what we know that they do. We actually don't know whether that's good or bad for patients. And I'm almost sure it's good for some patients and it's bad for other patients. And so what we do know from some of the data that was presented on individuals is that discontinuation of opioid agonist treatment is very bad for people. Their overdose death rates are higher after they're discontinued than before they're started. So this is getting at sort of the conversation we were having before about, what happens when people stop their prescription opioids. Like, that discontinuation is probably, it has a high risk of being a very bad thing. And that's the one thing we know that will happen to people when their provider gets a message through the PDMP about their opioid prescribing. So Brendan tried to talk about how to limit those unintended consequences and focused on harm reduction and treatment, which I think those messages don't rely on a risk prediction model. But your idea and Michael's concept of getting this information to an institution so they can see what the impacts of, on their population is, and then maybe allocate resources or figure out where they need to innovate on how to not just capture people at the provider-patient level, but maybe invest in some structural or new programming that can, try to engage, say, high-risk patients that are hitting their hospital or their emergency department, but actually they're not retaining or they're not able to affect their, their health behaviors.
Yeah, I mean, I'm aware of a hospital in a state that we all know pretty well that, has an inpatient substance use program that does not start methadone or buprenorphine for opioid use disorder. So it may not be that helpful to give someone a score if they don't have the ability to actually provide the care that the patient actually needs. Regina, any thoughts on this before we open it up?
I agree with on the institution level because the litigation that's happened against sheriffs, counties, states in some cases has spurred a lot of action, but that action it's pretty slow. It seems like lightning speed in the time that I've been working on this issue, but it's going to take a while. And for example, there's a state that had money in the budget that would have allowed for the state to pay for MOUD treatment behind the walls. That was vetoed by the governor in a line item veto. So that state then it kind of sets itself up for litigation when this is the kind of basic research that can spur action in institutions to see, especially risk managers, attorneys, to say we're at greater risk for financial liability if we don't do something about this.
Great. Well, I want to, we're going to keep talking, but I'm going to invite people to go to the microphones. Is that what we're going to do? Or Jonathan, are you going to?
One on each side.
One on each side. Going to pry the microphone out of Jonathan's hand here. And encourage people. I know we have a stacked audience of people who have a lot of experience on this issue, so please do not be shy. Why don't we get you started over here? And please introduce yourself.
I'm Ross Martin. I'm with CRISP, help run the research initiative there. Hi.
Ross.
Thank you. This has been outstanding. I had kind of two basic questions. I'll just start with one and I'll come back later if we have time. One is, if you had another data source, and this is more for the researchers, that you didn't get access to, that you wanted to add to it, and I'm impressed with the 40% of deaths that had no contributions from the data sets you looked at, and I'm thinking about what we've been hearing from EMS data, emergency medical services, and wondering if that was one, if we could add something like that, what you think you would find. I'll just go ahead and ask my second question just so you can tee it up. If you, how are you thinking about the sustainability of this evaluation? Like if you want to make this from a one-time looking at data from 2016 to looking at something that we're not necessarily using as live risk scores, but you're keeping this up to date and you're modifying it over time, how are you approaching that?
Great. That
it?
may be a great question for Michael too, because are there parts of this that you would like to have on your desk every quarter? So think about that. I'll turn to Brendan for the first question.
Yeah, great. Great question. And actually, on the first question, I also want to pose it to Alex from the Chapter 55 experience, sort of how you see the relative utility of different kinds of data, since you all went through a data matching process in Massachusetts with even a larger number of databases. So I think the two that we talked a lot about, first one was EMS data to get the ambulance runs. We think that those data would be really important in terms of seeing people who were treated for overdoses in the field but never went to hospitals. We know that a lot of people declined to be transported. I think the issue there, just being very practical, is that we weren't totally convinced at the time that we could get a good quality match of EMS records to our other data. And then I think the second one, which actually we had some serious conversations about, but just due to our bandwidth, we didn't explore further, was Medicaid. So Medicaid obviously provides a multi-site look at a defined population. Medicaid managed care organizations actually might be another important setting in which we could think about risk reduction interventions. So those were the two that we thought the most about.
Alex, do you want to answer that, and then we'll turn to Michael?
So there's two data sets that I would love to have. Brendan was mentioning ambulance was non-fatal overdose. We have that in Massachusetts. We couple it with emergency department visits. Non-fatal overdose is the single most important predictor of a fatal overdose. That's been shown over and over again. Except really the single most important predictor of a fatal overdose is how fatal your drug supply is. So we can do all the prediction modeling we want, but in a dynamic drug market, you're not going to hit the target. You can't predict the future. That's the one thing we've learned. And so we know very little about the lethality of the drug supply until people die. And so, it's not if you're taking a true public health approach, we can check the drug supply. It's being checked every day. Law enforcement checks it. And, more and more harm reduction sites are checking it. Susan Sherman's not here, I don't think, but she did a study that was funded by Bloomberg that looked at drug checking. So that, I don't think we're there yet to deploy it, but I think we have the technology and we could get there very soon. The other data set is, and I think this is, we could figure it out, but knowing what the extensive reach of harm reduction in the community is something we don't really know in our data. We know that syringe service programs and naloxone distribution are effective at engaging people, but they're really effective when those people are anonymous. And so it's difficult to get the same level of data, and they don't get integrated as well into the rest of these data systems. And they're a big player when it comes to overdose risk reduction.
Great. Michael, I want to go back to the second question to you, which is, is there any of this that you could think of would be good to have on an ongoing basis to convert a research project into a public health monitoring project?
Oh, I mean, all of it. And we now in Maryland have a state law very similar to what Massachusetts passed in 2015 that basically, at least for the next 3 or 4 years, requires the Maryland Department of Health to do a study like this with an annual report to the governor and the General Assembly. We are approaching this, at least the design of the data management infrastructure, the way we'd handle the study, in a very similar way to this predictive risk model project. And I mean, from my standpoint, just working within the state health department, I really feel like this kind of thing is within our grasp for sure. maybe not necessarily with the resources, the internal resources of a government agency, because as many of you know, state government by and large is a pretty low-tech affair when you're talking about the internal IT support. It's very difficult to do anything that needs a level of technology and ongoing support like this. But luckily in Maryland we have an incredible resource like CRISP, which I think does give us the opportunity to implement this and keep it going in an ongoing way. I've been, even though I've only been involved with this new state law mandated project for the past number of months, I'm optimistic that many of the same partners we worked with on the predictive risk model project, want to continue this and are going to want to contribute the data and get something out of it themselves, especially at that institutional level.
Yeah. David, do you want to add anything about?
Yeah, I think
what CRISP could
the
do?
thing that CRISP does, which is perhaps most helpful or at least unique in the process, and Jonathan referred to it, is the patient matching. An MPI that has lots of other data sources coming into it to improve the probabilistic matching really helps in trying to join data.
Great. Ju?
Hi, thank you for a really interesting session. I have a very specific
Maybe
question. I
introduce
think
yourself
my name is Ju Park. I'm an epidemiologist, harm reduction researcher at Hopkins. I have a very specific question for Lindsay. I was really interested to hear about the, has she stepped out? Yeah. Or somebody familiar with Great. I was wondering what proportion of the illicit overdose deaths actually were not affiliated with any prescription opioid or did not appear in the PDMP system at all. So that's a very specific one. And then my second question is about your thoughts on naloxone. Didn't get mentioned too much, but your thoughts on co-prescribing naloxone. I think the conversation has moved a lot over the years, and we hear a lot about any patient with opioid use disorder should be prescribed, or anyone coming into the emergency room. But based on these data and analyses, what are your thoughts on those policies?
Sure, come on up.
Ju, great questions. On the first one, I don't have that figure at my fingertips. It is something that we've run, so we'll be glad to follow up with you about that.
Similar to what I asked, though, so probably 60%, right? Your question was what percentage of all the overdoses that were illicit weren't in the database? So it's probably a good percentage.
Oh, sorry. I thought your question. So we did look at the share of illicit. It's harder to find fentanyl and heroin involved deaths in our data, but those individuals still do show up pretty consistently, especially in the hospital and specialty behavioral health data. Yeah. And just to put in a plug, Matt Eisenberg's research letter in JAMA Internal Medicine, I think, shows those data. So yeah, I would recommend that. So the second thing you asked was about naloxone. So unfortunately, to Alex's point, naloxone distribution doesn't get tracked in ways that we can observe. I think as a policy matter, that's an incredibly important intervention. Naloxone scale-up has been, part and parcel of a lot of efforts here in the state, but unfortunately, as you well know, naloxone often doesn't get to the people who need it the most. Just to put in a recommendation from the PDMP perspective, I think it would be incredibly important to have visibility of naloxone prescriptions with the PDMP data, and then we would be able to actually understand a little bit more about the prescription profiles of people who are co-prescribed naloxone. And I know that actually is already taking place in other states, just not in Maryland.
Yeah, prescribed and also filled as well.
Yeah, so it's interesting you mentioned that. I recently learned that an astonishingly high percentage of naloxone prescriptions are abandoned at the pharmacy.
Great. Any comments from anyone here before we move on?
Just that co-prescribing of naloxone, I think it recently came out, there was a paper, 4 states have mandated co-prescribing of naloxone with prescription opioids, and that shows a really large surge in prescription naloxone going out through the pharmacy. So I think that's a policy that looks like it's pretty effective in getting naloxone out there. Now, whether it gets them to the people who are highest risk of overdose, it definitely gets it to people who are getting an opioid prescription. So that is a risk category. but I think most of us believe pharmacy naloxone and harm reduction naloxone are, it depends on where you are, but are different types of naloxone.
Maybe they should be giving naloxone to everyone who leaves the hospital. Sorry, just
I mean,
given the risk,
these
you know.
findings
Yeah.
would support that. Yeah, in jails, right?
Do you have a question over here? And
Howard
please introduce
Burkham.
yourself. Yes.
Howard Burkham. I'm at Johns Hopkins Applied Physics Lab, been working on this problem for past 3 years. And I'm also concerned about the number of overdoses that don't show up in any of these data sets, because I have the feeling that this number is going to increase. In the recent University of Maryland National Drug Early Warning System presentation on addicts' feelings, there's a definite lack of trust, and a lot of people will not go to the hospital, plus the increasing and almost untrackable number of bystander naloxone rescues. It seems there needs to be a better way of reaching people who won't get into these data. In particular, I know that at poison centers, the percentage of calls related to substance abuse has dramatically gone up. And I'm wondering if any of these programs are connected to poison centers as another way of reaching people who might not show up in another data set.
Thank you. Why don't we talk a little bit about people who aren't in this data set, and if there's anything we can learn from the analysis that's relevant to them, or just in general, whether the recommendations actually might look different, because you don't want to just do recommendations for the 60% and not the 40% you don't see. So is there a good example of that was the naloxone issue, which is you can do co-prescribing naloxone, put it in the PDMP, but some people may not be visible to that at all, and that's actually a community distribution of naloxone to very high-risk communities that's needed. So as you think about the people who are not necessarily appearing in this, what are the top priorities, maybe, Regina, if you want?
I mean, I think that, Maryland has syringe services programs in a lot of parts of the state. I do a lot of work around the country where, believe it or not, syringe services programs are not widely embraced and actually are closed. And so, having syringe services programs obviously is another avenue for distribution of a harm reduction, including naloxone. And I think, when I was in the administration, we talked a lot about trying to get naloxone over the counter. I mean, all states now have more availability, but there really doesn't appear to be much of a reason why FDA shouldn't be pushing that more. And that's another way to get to more at-risk populations who may not be showing up at a hospital.
I think we need to invest in prospective surveying and qualitative data collection serially as part of surveillance. So just as an example, in Massachusetts, we have this data, and we have, through our statewide naloxone distribution program, where everyone's anonymous, we have ongoing calls on a monthly basis with the distributors of naloxone. And what we've learned in the last year is there's been this surge in methamphetamine, which is a whole new aspect to our drug market in eastern Massachusetts. We don't yet see methamphetamine deaths in the overdose data. We're not really seeing that much methamphetamine requests for treatment yet, but I'm expecting it's going to start to come pretty soon. And so, this is just one example of getting some sort of hold in the, people who aren't necessarily interacting with the system and are probably overdosing and having health events from it. So, investing in programs that engage with people who are marginalized and high risk, I think, is really kind of key, not just to provide care to them, but also to have a sense of what's going on epidemiologically.
So you could imagine a parallel universe where this talk is about people who don't touch any of the systems,
Exactly.
presenting data about what they're thinking and doing.
One innovation, and again, Brendan alluded to this in his talk, and OSOP, it sounds like a program that's happening in Maryland. It's very familiar to me, even though I hadn't heard of it till today, because in Massachusetts.
Can you explain what that is?
So I think it was Overdose Survivor Outreach Program.
Yes. So, I mean, that term in Maryland has specifically referred to a sort of build out that has been, funded by the state in partnership with a number of hospitals around the state and some expert technical assistance providers that work with those hospitals to basically bring on peer recovery coaches. So people, with lived experience of substance use in recovery, who work with individuals who are struggling, who are coming through the hospital emergency departments for an overdose or for other reasons, and not just seek to connect them to treatment and other services, but to really provide ongoing support to them. And so it's a model that's exists across the country in many places now. I think it started in Maryland going back 5, 6, 7 years ago. But it is one aspect of how the systemic changes are taking place, I think.
So I brought that up because in a couple cases in Massachusetts, we have harm reduction outreach workers who are part of these post-overdose outreach programs. And so if you overdose, you're in the data set, right? And you survive. So that, in some ways, you're talking about the parallel universe of the people who we don't reach. But one lesson we've learned from these programs, especially when they are paired with harm reduction workers, is that they're meeting people for the first time who never accessed their syringe service program. So these are people that up until the moment 911 was called, they were using drugs. They didn't have any other contact with the system. They were in this hidden 50% of people who don't interact with the system. And then they get that 911 call. Then we actually have had communities where harm reduction goes out and they're not connecting them through syringe service programs. So my point there is that existing harm reduction networks are really important for us to invest in, but we need to even go further than that. Even if we included them, there would still be a hidden population.
Because there are always new people too. So it's interesting. So I mean, basically what we're talking about is these data are really illuminating opportunities for the major institutional players to do better, because there are a lot of people at extremely high risk who are there. But in addition, there are areas of outreach that are really important for people who are not yet necessarily coming into contact there.
Yeah.
Question.
Hi, my name is Kisan Peters. I am the quality data analyst for Turkhouse. It's a substance abuse treatment in Baltimore. My question is, by analyzing different data sets and hearing about the presentation and the data today, it seems like the common or the mean age is between the 40s and 50s for a lot of these different data sets. And I wanted to know, particularly maybe from anyone, have you seen any trends for, I guess, the next generation of opioid users? Anything yet from maybe post-adolescence to today? And if so, what are those trends?
There was recently a paper that was published by some faculty here looking at adolescent drug use in a number of cities, and heroin use was extremely high relative to other cities in Baltimore. Other drugs were higher in other areas. We could definitely share that, but I was certainly open to the researchers if there are other comments you want to make about that.
Yeah, I appreciate the comment. Our data are from 2014 to 2016, so we don't have as much visibility of some of these more recent trends. Maybe others kind of can speak to the demographic changes.
Well, young people don't like to come to the hospital or go to the doctor. So it's even hard. I mean, you're a pediatrician. Like it's even harder to engage them, and that's reflected, I think, in the data. Like, we're not going to collect as much data about younger people because they're less likely to interact with these systems. So I think that's just a challenge. I think one thing it speaks to is we need to design addiction treatment and harm reduction programs that really work for these younger populations. and make it, so that they want to engage.
I want to. Oh, go ahead, Regina.
Well, I think it also points out an important point that you just made when you said that heroin use among young people in Baltimore is high, or relatively speaking, because nationally that's not the case. And from traditional demographic information in most states, and so we look at it as one big opioid issue when it really varies nationally. They're seeing it in Western Massachusetts with methamphetamine. The Western states say, look, we never lost meth. It's always been an issue, and it's surging, or it's getting more prominent. But we have different epidemics nationwide.
Great. We have one last question, and then I'm going to also ask, as you're responding to it, for you to make any concluding comments, particularly about the value of these kinds of collaborations, where it's not just monitoring, but it's really digging into research questions and what the future should hold for this kind of work. Go ahead.
Hi, I'm Crystal Harrian, and I'm from George Washington University. I have a two-part question. My first part is for Matt. I was wondering what you used to determine the opioid-related deaths. Was it like ICD coding?
So for all of the deaths we examined in all of the papers, they came from the Office of the Medical Examiner. So those were investigated deaths, and they ruled that they were related to opioids.
There was toxicology.
Yeah, there's an extensive protocol they use.
Thank you. And then my second question is for the panel, since you were talking about some of the unintended consequences of having the PDMP and kind of reducing the amount of things such as Percocet and Oxycontin that are out on the market. I'll share with you, a month ago, my 20-year-old brother died of a drug overdose. He thought he was purchasing Oxycontin, and instead he purchased it illegally, of course. He got something that was contaminated with fentanyl, and apparently this is causing a lot. He was 20 years old. This is causing a large number of deaths, especially in rural Maryland where he was living. And I was just kind of wondering about your thoughts about kind of that being an unintended consequence, and whether there were any data sources that might be available to kind of bring some press to this as an issue, especially when we want to deter kind of our next younger generation from taking something that they might think is relatively safe, like a Percocet or an Oxycontin that somebody might take for back pain, and instead they're taking fentanyl.
Right.
Thank you.
Yes. Thank you very much for sharing that. I'm very sorry to hear about that. I think, this obviously puts a human face on the potential for serious unintended consequences, to the potential. And I wonder if any of you have any further thoughts about that. I think that there was a whole wave of studies that really just used prescribing as the outcome. And I think there's been a lot of appreciation that just doing something that reduces prescribing in the emergency department isn't a great outcome if there potentially are other harms that people are experiencing.
I'm really sorry for your loss, and it does put a human face on this issue that we deal with kind of from data every day. But I think that Alex said earlier about the safety of the drug supply in a lot of states. Drug testing kits, drug testing strips that can test what a drug is that someone may be taking. It's illegal. It's considered drug paraphernalia. And so those are, kind of policy responses that we should be looking at it holistically. But drug testing strips are cheap, and they can be used to sometimes keep people safe.
And I just want to second that in the context of a specific policy changes, like addressing legal barriers that are the paraphernalia laws, and interventions like making testing strips and other practices available. But I think just the broader issue of really, it's just beyond a discussion. I think at the policy level, of recognizing that people who are actively using opioids and other substances, it's not just that they have health and other social needs, it's that they deserve to be treated as folks that are worthy of the investment of these systems and officials and the public dollars that are coming in. And it is, in my opinion, it's not just unacceptable, it's just wrong to operate on this assumption that people aren't worthy of that support and investment until they have made a decision, or that they're going to stop using and they're going to come in to the services that we're offering them. And I think, everything under the harm reduction umbrella, it just, and even at this point in this crisis, it's really just sort of an abysmal state of investment in that. And I think we need to get way more aggressive in Maryland and across the country in making that investment, because lives are at stake, and I think people deserve it.
Great. Thank you. And I'm glad Jonathan's up here because I can ask him also for this last question. I think, from my perspective, the work here reflects extremely well on the work of the researchers, but also on the state of Maryland, that it was willing to share these data and really permit, investigation of a lot of really important questions. And I think from my perspective, it reflects the kind of partnership that can lead to different kinds of answers, not the perfect answer right away or some magical solution that we would all love to have, but really help to push things in the direction of policy that's guided by evidence. So I guess my last question for everyone, and I'll put you on the spot, Jonathan, is like having worked on many different kind of big data projects, what you see as the future of this work and the real value of it.
I got up actually. Thank you, and thank the audience. Let me answer you, and then I'll do that. I think, as I started, data are necessary. They're critical, but they're certainly not sufficient. And likewise for academics, that peer-reviewed article in JAMA Internal Medicine or a journal of public health is necessary, but not sufficient. We're not here just to publish. We're here to have an impact. And I've been involved, as you say, in many projects. I can think of none that has had more potential immediately to help people. And I think it's absolutely, there's no excuse. The data exists, and the hardest part of the whole project is the people that work very hard in the state agencies. And again, for the third time, I'd like to thank every state agency at the risk of showing where some of the challenges are. They share the data, but they and we and everybody in the room is here to make a difference and to help people. And you never thought of those little bytes, ones and zeros, actually have a way of helping people. And like I said, not just selling us stuff that we may or may not need, but impacting people's lives. But as we've heard, the panel, I would say 90% of the discussion wasn't about data, but 90% of the discussion, the things you talked about, could not have happened without the data. And that's the point I'm trying to make. And absolutely, one of the reasons we're having this group, and I do also want to acknowledge the 50 people or 100 people that are watching online and the 1,000 people that will watch this archive. This is really the beginning, not the end. I hope we're very easy to find. Myself, Jonathan Weiner, or Elise Lasser, the center coordinator, and all of the fantastic both panel members and specifically Hopkins faculty. We want to be contacted. And I will promise that we will try to be constructive responding, of course, with resources and lawyers. I'm glad we have a public health lawyer. And I meant what I said. There are many impediments. Hopefully the Chapter 211 here in Maryland was meant to clear some of those impediments. And yes, you made that comment. There's no excuse for the state of Maryland or the city county health departments not having access to the stuff that a 3-person startup have 3 times more than a how many thousand person agency have. So that's one reason CFIT and other people want to bridge that gap. So again, thank you for Josh. That's the main reason I got up. You've done a phenomenal job. You're able to bridge it. The panel members were fantastic. And everybody stayed right on time. And all of you who came, you have a lot of other alternatives that you could spend. I hope that you can, those of you here in the room, we have the Anna Bacher room, also W1030, which is toward the Wolf Street building. We hope to have an interaction where you can get a chance to talk to hopefully most of the panel and most of the presenters.
Great. Well,
So-
please join me in thanking the great panel that we had here.